Good afternoon and welcome to the AYA meeting. We're going to get started.
I don't think your mic is working.
Is it on?
Oh, it's on.
All right. There we go. All right. Hope everybody got a snack. For those logging in by Zoom, thank you for joining. I'm Becky Johnson. I'm the chair of the AYA committee. Here with Dr. Lucia Nappi, the co-chair, and Allison Rosen, who's our patient advocate. And we've got a very interesting lineup of talks for you today. We've got Kristen O'Dwyer, who's going to spend about half an hour or so talking about ALL trials up and coming within the NCTN network. And then Dr. Davis, Laura Davis, is going to update us. She's our Early Therapeutics Rare Disease Cancer Committee liaison. And so she'll tell us what's been going on in that group. I've got a few updates on initiatives that I've talked to you about previously, and we'll spend a few minutes on that. Then Melissa Boscheman and Allison Rosen are going to talk about a very recently funded pilot project through the Hope Foundation, looking at AYA clinical trial messaging and how to promote that through social media, especially within minority groups. And then Dr. Danishman, a GU oncologist, is going to talk about clinical trials for early metastatic germ cell tumors, and then we'll wrap it up. So before we get started, I want to make a plug for liaisons for this committee. So as the AYA committee grows and becomes more formal, we're looking for liaisons to each of the disease-specific committees and also the other support committees, NCORE, CCDR, survivorship, palliative care, et cetera. We would love liaisons, people who will go to those meetings and also come to these meetings and report back. And so if you're interested in that, it's a nice leadership opportunity. It could be set up in a couple of different ways. For a junior investigator, it's a great opportunity, but you might still need some help navigating your own home committee, in which case you might be able to be paired with a mentor within that committee to help out as well. And if you're a more kind of mid-level person who's wanting more responsibility within your home committee, it's a great opportunity too. So if you're interested, please let me know afterwards, and or the head of your disease committee, and we'll get that formalized. It is a simple process without a lot of red tape, so should be easy and fun. Now I'd like to introduce Dr. O'Dwyer to talk about ALL.
Thank you so much for having me and for inviting me, Dr. Johnson. So I'm going to talk about two trials specifically that have been developed in the last year that will include, that are including the AYA group, and one of the trials actually is children less than 18. So move my glasses. So pull your mic towards you. Is that better? For in the ALL space, we really work together across NCTN groups with under the leadership of Dr. Wendy Stock, who is the leukemia chair. And she has gotten all of us together. We have been meeting since January of 2020, right before COVID, and senior and junior investigators meet approximately every 2 weeks. We have vetted multiple trial concepts, presented original research that could inform new trial designs, and presented also research that could inform correlative science objectives in the trials that we'll talk about. So there have been, so far, since this group began, there have been 2 clinical trial concepts that have been approved. One is for our older adults with that I won't talk about today because it it is for our older adult population with Philadelphia chromosome negative BALL. And that is being led by Marlise Luskin and Elias Jabor. And then a second that I will talk briefly about is it's a single arm phase 2 trial of daratumumab for MRD positive patients with T-cell ALL. And because T-ALL is generally a disease of young adult patients, we can spend a minute talking about that trial, which is currently open. And then there are 3 concepts in development. I'm going to talk about 2 today, S2306, which is a frontline protocol for patients with T-ALL and T lymphoblastic lymphoma. And then a second one, S2307, which is a frontline treatment for patients with KMT2A rearranged ALL or acute leukemia of ambiguous lineage, and that's being led by Ibrahim Aldos from City of Hope, and he allowed me to share his slides today. And then we're working on a relapse trial that we hope can also bridge the entire age range, but that one we're still working on, and it's in development. So in general, I'm showing this slide. This was data from the first young adult trial for ALL, CALGB-10403, that was led by Dr. Stock. And this is just meant to show that our end of induction MRD analysis around day 29 following induction is probably the most important prognostic factor that we have. So many of our trial designs, the primary endpoints are all focused on how do we improve more patients to have an MRD negative remission at the end of induction. In this first trial, CALGB-10403, approximately 43% of patients had undetectable MRD. And you can see that the outcome is significantly better if they are MRD. So that's sort of the theme. We're trying to design trials that we think can lead to better remission status. So that the frontline trial that is currently open, it's led by the Alliance, led by Dan D'Angelo at the Farber. It's A041501. So this is the frontline chemotherapy backbone of CALGB-10403, which is a pediatric inspired backbone. And it then randomizes patients to receive or not receive 2 cycles of inotuzumab ozogamicin, which is an antibody drug conjugate against CD22. This trial has been in process for several years now. Approximately 279 patients have been accrued to date out of a total of 341. Recently, this trial had to be put on hold, however, because there was a toxicity signal in the experimental arm. So there were a few deaths, all in the arm that received patients who received inotuzumab, and they were all deaths related to sepsis. So this trial has been put on hold for the last several months, but I believe there is an amendment coming that is meant to make this trial safer. We probably, with the effectiveness of some of these immune therapies, we're trying to cut back on the chemotherapy blocks that we're using. So with permission, I was told what the amendment proposal is to remove that delayed intensification arm, which is the 4th high dose chemotherapy block in a basic ALL trial, replace it with blinatumomab. And that is based on data that was presented at ASH from another NCTN trial, E1910, that showed all patients, even MRD negative patients who received blinatumomab in consolidation, had significantly better outcomes. So we're hoping that we can reduce the toxicity and replace that 1 high dose chemotherapy block right before maintenance delayed intensification with a blinatumomab substitution. Also, there's going to be stricter antibiotic prophylactic guidelines and things like that, but that's the main difference that will be incorporated into this trial going forward. Second, we have an open trial for our Ph positive patients with ALL, and this is a frontline chemotherapy phase 3 trial led by Yishai Ofran in Israel, and he's a member of ECOG. So this trial is randomizing patients to receive either TKI plus our hyper-CVAD based chemotherapy versus tyrosine kinase inhibitor plus of physician choice, dasatinib or ponatinib with blinatumomab. So hopefully moving towards perhaps a chemotherapy-free regimen for our Ph positive ALL. And I mentioned the daratumumab trial. Again, this is open throughout the NCTN. And so for patients who have are in remission, but have developed MRD or never cleared their MRD. This trial will be, it's a single arm trial, a small trial of about 20 patients to administer 4 weekly doses of daratumumab to see if that can clear the MRD, and then patients can go on to transplant. So those are the open trials that are in the NCTN for our young adult patients. And then I want to present 2 trials that are in development that should be open, we hope, this year. The first is S2306, which is a randomized phase 2 trial of chemotherapy plus or minus BCL2 inhibitor therapy for patients with TALL and T lymphoblastic lymphoma. So again, historically, it was the outcomes for TALL were at times thought to be inferior. Some trials show that they're better than B-cell ALLs, but with a pediatric inspired regimen, it has been shown that the overall survival by immunophenotype is equivalent with the chemotherapy backbone. And this is data from the CALGB trial 10403, which included both B and T cell patients. Our historical control for T cell ALL when we used the more adult style regimen was about 48%. So we're going to add to this. So TALL, it's curable for most children and young adults. Again, about 70% of children and young adult patients will be cured with just contemporary frontline chemotherapy regimen. However, when patients do relapse with TALL, the outcomes are very poor. We have no good salvage agents for TALL, unlike in our BALL patients where we have effective immune therapy such as blinatumomab, which is a BiTE antibody against CD19. We have inotuzumab, which is the antibody drug conjugate against CD22, and of course, CAR T therapy. We have none of that in TALL. And so when patients relapse, it's incurable for most, with an overall survival at 5 years of less than 10%. Nelarabine is the only drug that's approved by the FDA for relapsed TALL, but now we're incorporating that into our frontline regimens as well. So although there's no good effective agents now, there are early off-the-shelf CAR T therapies that are in development and are at some specialized centers. So we know that based on a lot of preclinical data, looking at the BCL2 inhibitors in TALL, that lymphoid malignancy in general are known to evade apoptosis by upregulation of pro-survival BCL2 proteins such as BCL2, BCLX, and MCL1. In TALL, it's unique in that the maturation state of the T lymphoblast, wherever it gets held up in the development of its TALL, determines which specific pro-survival protein on which it depends. So for example, immature subtypes of TALL, such as the early thymic precursor, the ETP-ALL, are much more dependent on BCL2 than they are BCLX. But then more mature subtypes of TALL express lower levels of BCL2 and then overexpress BCLX. So venetoclax is a BCL2 inhibitor that's widely used in adult leukemia, and it's a selective inhibitor against BCL2. Navitoclax also inhibits BCL2, but also BCLX and BCLW. Navitoclax was the first generation BCL2 protein, but it was limited in its clinical development because of severe thrombocytopenia. But with lower doses of navitoclax, there has been trials showing that it can be very effective in this space. And most of this data has been shown by some BH3 profiling, which is a technique, it's a laboratory method to detect dependencies of these specific proteins for cell survival. So this is data from a phase 1 trial in relapsed ALL, both B and T cell, where BH3 profiling was done for patients who entered this trial. And what you can see in the bottom, the T cell ALL patients are in the red box below, that those TALL samples with BCL2 dependence at baseline over the course of treatment switched to a BCLXL dependency, while the B cell patients really maintain their dependency on whichever BCL2 protein was expressed. So based on this data from from relapse and refractory patients, we designed the trial for our frontline therapy to use both of these medications to try to eliminate any kind of resistant population. So this trial has been in development, Anna can attest, for about 2 years. The first version that was submitted to the NCI was just it was simpler than this, what you're seeing now. It was 2 arms. It was the chemotherapy backbone versus the chemotherapy backbone plus navitoclax and venetoclax. The NCI they did not approve that first version. But they recommended that we do a 4-arm trial. They really wanted to isolate the effects of the individual experimental agents, which makes sense in retrospect. But again, our idea behind this trial was that we want to eliminate all the potentially paths of resistance early on. So we are still hopeful that that 4th arm, which has the chemotherapy backbone plus venetoclax and venetoclax, will be the helpful one. But regardless, we're going to do this 4-arm randomization. We'll have a safety run-in because we've never combined these agents with our backbone chemotherapy in our young adults. So the first 10 patients, the way that the NCI recommended is that they all get the combination therapy and look for toxicity signals there. Once the 10 patients have gone through, and if there is or if there is not a signal, then hopefully there will not be with some of the safety parameters that we've incorporated into the trial. But then the randomization will start. So people will be randomized either to the chemotherapy arm alone, to the chemotherapy arm plus venetoclax, chemotherapy plus navitoclax, and then finally the combination of navitoclax and venetoclax. So the primary endpoint for this trial is the day 29 MRD. Again, that was not, The first 10 will all go into arm 4. Correct. For the safety run, and they'll all go in, and we'll watch them throughout delayed intensification. So we'll watch them through all the high dose course. We'll watch them all the way through DI. And that's again, based on what's been happening with our current young adult trial for BALL, that there was a toxicity signal seen there. So we will watch them, those 10 patients throughout the first, 4 to 5, 6 months of therapy. Yes. So and then there's also actually 2 other cohorts to this trial. But before I get to that, so the primary endpoint will be day 29 MRD. But we'll also measure the day 78 MRD. If patients are still MRD positive at day 78, they will be encouraged, or they could go on to the T-cell trial for MRD positive patients, or based on a discussion with their primary treatment physician, they can either stay on study if they think they're getting some benefit, or go off to transplant, or go off to get something else. And then we're going to compare the MRD values at both day 78 and day 29 and through all the arms. And that's how we'll decide which of these arms seems to be the best. The second and third cohort. So of patients with TLL, approximately 25%, patients who have T lymphoblastic leukemia lymphoma, about 25% of those patients will have no bone marrow involvement, but just extramedullary disease, primarily mediastinal mass. Generally, these patients historically have been excluded from trials. But we treat them the same. We're not sure if that's the right thing to do, but that's what both the SWOG and with the adult cooperative groups have not allowed them on their clinical trials. But we're gonna do an experimental cohort for them. We'll treat the first 10 patients again, just as a safety analysis, because again, these patients have not been allowed to enroll on our trials. And in the SWOG experience, for example, the AAA LL 0434 trial, which was a very large trial for T-cell ALL. They did allow patients up to age 30, but in our group, we're allowing patients up to age 60. So we just do want to test the safety of the pediatric regimen in even our older, younger adults. So the first 10 patients will be watched for safety, and then the next 10 patients will be non-randomly assigned to receive the combination, if we have determined that it's safe, the combination regimen of navitoclax and venetoclax. And then we'll have a third cohort of our older patients not truly older, but older for a young adult population. So anyone age 40 and above, even though it's a rare patient that is with TLL that's over the age of 40, but we all treat them in our clinics. And there's really no standard of care in this setting. So we hope that with some dose modifications that have been shown to be safe, mostly, again, the dose modifications for older patients up to age 60 have been conducted by Dr. Stock at the University of Chicago. So we have these dose modifications incorporated into the protocol, and we want to try to establish some sort of standard of care so that perhaps for the next trial that would go into development for our T-cell patients, we could have all of these patients under one trial. So again, the first 10 patients will be assessed for safety with our dose modifications. And then the next 10 will be non-randomly assigned to receive the experimental therapy of the combination of venetoclax and navitoclax. So that's a complicated trial. Here's just a table showing the summary of the cohorts and the primary endpoint. So we expect that it'll take 2.5 to 3 years to accrue more than 100 patients for this trial. And then we'll have almost 3 years of follow-up. So this overall will take about 7.5 years to complete. So again, our safety run-in is, again, it's a confirmation of tolerability. We hope that we can accrue about 10 patients over 6 months, and that's just based on the accrual data from our experience in the CLGB 10403 trial. If fewer than 3 out of 10 patients do not experience toxicity, then the randomization will start after we watch them through delayed intensification. We're going to encourage growth factor support to limit prolonged myelosuppression. That's the toxicity that we're worried most about with adding venetoclax and navitoclax. It's myelosuppression. This will be open to all sites as long as the treating investigators are willing to participate in bi-weekly calls to review all the patients on trial. Again, we're looking for the toxicities, the induction-related mortality, which in 10403 and A041501 is less than 3%. So we know this is a safe regimen to give. We want to continue to make sure that it's a safe regimen. We'll be looking for, again, myelosuppression is what we're most concerned about, and especially in combination with multiple agents that we use for ALL. Neurotoxicity is another toxicity we'll be looking for with the addition of nelarabine for our young adults. And so any questions on that trial, where it's been approved by the Leukemia Steering Committee and the NCI, and we finally got drug approval about a week and a half ago. So now it's a go. And we're in the protocol development stage, and we're submitting it to the PRC in the next 2 weeks. Oh, is that a week from? So yeah, the 17th. So we hope our drop dead date is in January, right? But we hope, so we hope to have this open optimistically before the end of the year, but it probably will bleed over maybe to the early part of 2024.
Well, I have a question. What's the growth factor support going to look like? And has that been in any previous trials at all for leukemia?
So we in the adult trials, it's an investigator discretion or just institutional standard. So we're going to recommend that following it, so that the way that the venetoclax or the navitoclax or the combination will be given on days 1 through 14 during induction, also days 1 through 14 during consolidation. So after that's completed, then we'll recommend some growth factor support, and whether Neupogen for the white cells, and then also Dr. Stock is recommending that we maybe even use Eltrombopag if you can.
Because theoretically, if they had prolonged myelosuppression, they'd have like a 6-week
Correct.
lag in getting any chemo.
Correct. So we don't
Yeah.
want that, you know. Yeah. Yeah. So. But again, in T-cell disease, once you have relapse, there's really little we can do. So we're really hoping that this combination will allow us to see more MRD negative remissions. And we hope that that then translates into a better event-free survival and then overall survival. That is our goal. And then the second trial is a trial that's been designed by Ibrahim Aldos from City of Hope. He's one of the adult ALL, and he's also a transplant physician. But you can see, and Dr. Advani Megan has been working with this team as well, and Jen McNear and Elizabeth Rates are from the SWOG, and Wendy Stock is, of course, helping us with this. So KMT2A rearranged ALL is a high-risk subtype, and the outcomes are really unsatisfactory with our frontline chemotherapy regimens. This type of rearrangement can also occur in acute leukemias of ambiguous lineage. So they will also be eligible for this treatment. And historically, in our adult trials anyways, we've not allowed acute leukemia of ambiguous lineage to enroll. So this is another good thing for us. We're happy to finally be incorporating some of these rare subtypes. But even after a bone marrow transplant, most patients would be recommended to go on to allo. The relapse rates are quite high. And then this type of chromosome rearrangement of the 411, they have this propensity to undergo lineage switch, meaning so even some of our immune therapy is not as helpful in the absence of perhaps going on to transplant. So, and they also don't respond as well to anti-CD22 therapy. So two of our best salvage regimens or things that help clear our MRD are not as helpful in this patient population. So, this KMT2A rearrangement, it leads to this aberrant expression of the homeobox genes and their DNA binding cofactor. And so this gene expression program causes hematopoietic differentiation, a differentiation block, and thus leukemia transformation. And so for these leukemias that are driven by KMT2A rearranged translocations, this transcription of menin is a critical oncogenic cofactor, and you can see here in this cartoon. So there are new inhibitors that block the menin KMT2A interaction, and it disrupts this assembly on the chromatin. And so those inhibitors have been used in the relapse refractory setting, but now even the outcomes are not good in the upfront setting either. So the idea is to bring it into the front line. So this is the first in human phase 1 trial of the compound that will be used in this trial. It was an oral selective inhibitor of the menin KMT2A interaction. The study drug was associated with low frequency of grade 3 or higher treatment-related toxicity, the main toxicity being QTc prolongation, and also it causes differentiation syndrome. But the response rates were quite in this relapse population were pretty impressive. The overall response rate around 59%, and the MRD. And also for patients who were in remission, their MRD negative rate was quite high as well. So that led to that, well, if it works in the relapse population, maybe we should bring it up earlier in their therapy. So the hope is that combining it with our backbone chemotherapy regimen, it will be safe and well tolerated for this patient population. And this, again, because this rearrangement is found in infant ALL and throughout the age spectrum, and everybody has trouble with it. So there will be 3 cohorts in this study. First will be, for patients, 1 to 17, and that will be led by the SWOG, and the treatment regimen was designed by them. And then we have our usual kind of young adult population, the 18 to 49-year-olds, and it will be, again, using that backbone regimen from C10403, adding the oral inhibitor to it. And again, this will be administered during induction. This drug will be administered through all of the components of the high dose chemotherapy components as well as maintenance. And then for patients who are older than 50 with this rearrangement, they will also have a protocol with age-adjusted hyper-CVAD. I think in looking, a lot of people use hyper-CVAD for this patient population. So it was trying to see how combining it with that regimen, if that would be safe and effective. So that's the trial design. This one isn't as far along as 2306, but it has been approved by SWOG. And I think it's going to the Leukemia Steering Committee soon.
I'm not sure what that is.
It's soon, yeah. So this one is hopeful that it'll get approved, but it's at least gone through SWOG and it's been approved, and it's been approved by the SWOG. So they're getting ready. If not, unless they just in this past week maybe have even presented to the Leukemia Steering Committee. So,
Can you talk a little about the collaboration between the groups? It's great to see these prospectively designed trials that apply to all age groups with this genetic subtype. So how did you choose 49 as the upper limit for the pediatric type protocol?
I think because I don't know exactly why in this trial versus our other one where we're using up to 40 and then 40 and above. I think to align it with some of our older adult trials that are really starting at around age 50 for the one that I briefly talked about that Dr. Luskin is leading with Elias. So I think it's to align with that. Yeah, we are trying slowly with all these trials that are out there to make them make sense as far as the age cutoff, because it can be arbitrary, right? So there are going to be dose adjustments for patients who are above, between 40 and 49. But I think it's because we have trials for 50 and above in the pH negative space that is using hyper-CVAD. So making it align with that. That's what I'm pretty sure as to why they're doing that.
Okay.
Yeah.
Right.
Yeah. But that's all I had. I can answer any questions.
Questions for Dr. Aguirre?
Oh.
So I saw, in your initial slides that you said that this NCTN working group had been meeting since kind of the early pandemic on a regular basis. And
Yes.
Can you talk about those meetings and just the pediatric and adult collaboration, which has been so impressively evident in the design of these trials? Like what were the easy parts? What were the hard parts?
Well, the easy part is that if you have Wendy Stock leading anything, everyone wants to participate. So that's awesome. But it's just open, which is, I think, what has been the best. We meet every 2 weeks via Zoom, and everyone is invited. It's not limited to anyone. And so, and it's just to present what you think. And she's really focused on junior investigators trying to lead some of these trials. So inclusion from, the ground up. So I think that's what's made it so fun for everyone. And it's just, and meeting every 2 weeks, you just keep moving things forward, even slowly, but everything is moving forward all the time. And so that I think has been really, really helpful.
And who supports those calls? Like, is it Dr. Stock's group? Is it CTAP?
Dr. Stock Sensibola, through her, but everybody participates. I mean, there's usually between 20 and 30 people on the call. Right. And it varies too from, there's been a lot of supportive care ideas coming through, as well as I've shown just the treatment trials, but there's a lot of other interesting things coming, the correlative science that's coming through. So it's just comprehensive in that way. It's not just about the treatment trials. It's about other AYA related, ALL things.
Nice.
So,
yeah. All right. Thank you.
Anything in the chat just before?
No.
Okay.
All right.
Well, thank you, everyone.
Thanks.
Thank you.
All right. Dr. Davis.
Hi, everybody. I'm Laura Davis, coming to you from Oregon. I am the liaison from the Early Therapeutics and Rare Cancers Committee. And I don't have a ton of updates, but I want to kind of keep the communication going. Becky had asked me to kind of just mention a little bit about how I became a liaison, so that you all can know how to become a liaison. And what you do is you just ask if you can be the liaison. So, for example, if any of you are really excited about this Early Therapeutics and Rare Cancers Committee and want to be the liaison, come chat with me. I would welcome having, if somebody junior wants to kind of transition into that role, or if somebody's just really gung-ho about getting more involved, happy to do that. I also happen to be the liaison from survivorship to early therapeutics, so also could have somebody who's interested in that take over. And it is very, very, very grueling application process and preparation process. So
It's super helpful, obviously, to both committees to have that crosstalk. And so I'm optimistic that we can get this information about AYA relevant trials out better to the SWOG membership with a more robust liaison structure.
I was taking notes on my presentation for tomorrow at this Early Therapeutics Committee to be able to present a little bit about what's going on here. All right, so just a few, I really don't have very many slides, and it's mostly just notes to remind me of what I wanted to tell you guys about. So there are a couple of trials that are currently open through this ETRC committee that are potentially relevant to AYA population. None of them are totally specific, but extrapulmonary neuroendocrine carcinomas, there is a fairly new trial currently open and enrolling for that. The DART combined immunotherapy trial for rare cancers, hopefully everybody has heard about that. That's actually just closed. So thank you all for your support. Almost 800 patients were enrolled on that trial. And really some very, very cool positive cohorts coming out of that with some nice correlative work. So I'll get the most updated information tomorrow and be able to present that, I guess, next time, or I can give you send you an email to send out. And our committee is going to be in charge of the SWOG portion of combo match. So, it's kind of the match for the new generation. And I don't know a ton of where that's going, but if you're interested in that sort of thing, come on to the committee meeting tomorrow morning. I think it starts at 9:30 tomorrow morning. So we have had a sarcoma working group, NCTN, AYA, SARC working group, very informal AYA group that Aaron Weiss, who was the PI from the soft tissue sarcoma SWOG protocol a few years ago. And he worked really closely with NRG developing an AYA sarcoma trial and went through all of the kind of growing pains and struggles of that development. And kind of out of that, he and Lisa Kopp started just kind of polling the people that they knew were interested in AYA sarcoma care and might be developing concepts that would be relevant to SWOG and SWOG or ECOG-ACRIN or Alliance or NRG, and just try to make sure that we're all aware so that there's less kind of competition, more collaboration. And this has been going on for several years. I think it is definitely different than the ALL group. For one thing, sarcomas are like 100 different cancers, right? So the sarcoma AYA group is much more like specific to synovial sarcoma, for example, or specific subtypes that absolutely happen across the age range with some degree of frequency. And just kind of talking through it, seeing if we should, is it a concept worth pursuing? Should we open it in both across COG and the adult groups? And I will tell you that this is very cool. I love it. And it has been limited just to just a few people to have it not be giant. So there's a few members from every group so that we have representation from all of the NCTN groups and SARC as well. But this has actually come back to bite us a little bit because NCI knows about this group and thinks that every sarcoma concept is discussed. But of course, if we're talking about a liposarcoma trial, we don't necessarily talk about it at the AYA group because it's not that common in the AYA patient population. So it has led to some conflicts with kind of communications between NCTN groups and CTEP. So as an aside, we're actually trying to improve that. So kind of as a direct result of that difficulty in communication, we have gotten together as all of the NCTN leaders to talk about how we make sure we actually get concepts approved through CTEP and really move things forward rather than kind of having this back and forth and competition instead of collaboration. So we now have a formalized leadership group of all the sarcoma committees and or working groups across the NCTN, and actually including Canada now and EURTC. We're bringing everybody in to start to make some more headway, and that'll cover all things sarcoma. But of course, the AYA group will continue to focus on things that should be open at COG and the adult groups, and then this sarcoma leaders group will cover that plus the liposarcomas, et cetera.
Are you concerned about that expansion beyond the AYA range, or is it a good thing?
Well, I've been spearheading it, so I think it's a good thing. It was absolutely necessary because we were not talking.
Yeah.
We were not talking at all. Mm-hmm. And then this AYA group was this kind of fun group where we chatted, and everything was really relevant to, is this something that we should be opening at COG or not? And why wouldn't we want it going down to age 12? Very focused on AYA issues as opposed to like all of sarcoma.
Mm-hmm. And how do you guys do your work in the SARC collaborative, right? Do you have conference calls? Do you have some in-person meetings now that you can? How are you?
The AYA meeting is every 2 months, video calls. And then the NCTN leaders meeting is, we just had our first conference call. We have like an informal meeting at in person, and then at a first formal conference call. And now at ASCO, it's like we're doing it. We've got the CTEP rooms. Mm-hmm. Yeah. So we're gonna make some progress. There are, and I should have started by saying that the activities within ETRC there's a lot of stuff going on, but as far as AYA relevant things, they really mostly are within the sarcoma working group. And if I learn anything beyond that tomorrow at our meeting, I'll make sure that to update Becky. So there are some trials that are open and very relevant to the AYA sarcoma community, both through COG and ETCTN, the early therapeutics group. Please, yes, absolutely make sure that we're doing some cross enrollment. The first trial on here, 2031, is one of those questions that we really need to answer, but everybody has really strong opinions and on one being better than the other. So this is a trial of opening up your chest to cut out osteosarcoma mets or doing it thoracoscopically. And everybody has very strong opinions. So enrollment is challenging, but it is such an important question, because if you ask, it's 50-50 on who thinks which is better. And it's not something that is as obvious. 2032 is for newly diagnosed osteosarcoma. There are cohorts for metastatic disease as well as localized disease, both previously untreated. And then, of course, we have a high-risk rhabdomyosarcoma trial through SWOG. At SWOG, within our sarcoma working group, we're developing 2 trials, but neither of them are particularly relevant to the AYA population. And I will say that one of them is for high-risk extremity soft tissue sarcomas. And clearly that is an important AYA topic. However, this trial does not include chemotherapy. Chemotherapy is allowed afterwards. And the standard of care within SWOG is very, very strongly to include chemotherapy. It is definitely not standardized in any way, shape, or form outside of pediatric care, and so this trial is more open, allowing chemotherapy afterwards. And so when in discussing that at the AYA group, for example, the appetite to kind of pursue opening at SWOG or to younger ages, but it was a good discussion to have. And then most excitingly, we have just been approached by SWOG to co-develop a MPNST concept with them, which I think will be highly relevant to the AYA population. MPNST definitely happens across the age spectrum, and that's going to be adding in MEK inhibition to chemotherapy, surgery, and radiation for this really very nasty disease. So yeah.
All right. Thank you. Any quick questions for Dr. Davis? All right. Great. All right. I'm going to give you a couple of quick updates regarding projects that you've heard about in previous meetings. This one is the AYA vaccine study for COVID vaccination and the response of patients that are immunocompromised to new vaccination. And Dr. Brad Pollack did a really fascinating talk, as you may recall, at our last meeting. And this is a very, nice response with a clinical trial that was created, in relation to the COVID pandemic, and a lot of potential information to be learned. It is an AYA relevant trial because they're recruiting up to age 37 for some odd reason. So, most AYAs are in fact eligible, as are children. This is the current information that they're giving out to patients and providers to try to recruit people for the study. But one piece of information that nobody could have predicted was the politicizing of getting the vaccine versus not getting the vaccine. And so in the past 6 months since our last meeting, the accrual for this study has really flatlined because no one new is getting the vaccine. People are maybe getting boosters if they've already had them, but there are no patients who get cancer who also then want to start getting the COVID vaccine. Very few of them. And so they are now, the study team is now looking into what to do about that. You can see the eligibility in the third bullet point includes most types of cancers. So many of our AYA patients would be eligible for this. And what they're actually considering doing is going back and retrospectively, allowing people to enter the trial who are immunocompromised and have previously gotten the COVID vaccine, which will dilute their data signals, but maybe the only way that they can recruit new patients. So stand by for further information about that. They're recruiting through the NCORE. It's a pretty easy study to do in terms of enrollments, and I will let you know if anything changes. But if you have patients who get a COVID vaccine and are also newly getting cancer treatment, they would still be eligible at the moment. So that's one interesting thing. This is EAQ 202 that John Saltzman had talked about at our spring meeting last year in Seattle. And this is an ECOG Akron-led trial going through the NCOREs, looking at patient-reported outcomes for AYAs with cancer. So it's an AYA-specific trial looking at the feasibility and acceptability of AYAs completing PRO batteries that are their choice versus a fixed set. So they can either choose the topics that are the most interest to them, like, a financial toxicity set of questions, physical health set of questions, or they can be given a standard arm. And what they're looking for is to see the trajectories of health-related quality of life during the first months of cancer treatment in AYAs, which will be interesting. Also looking for financial toxicity from the mouths of the patients in this population. And then they're asking the AYAs in the study how they want to be asked about their experiences and how they should give the PRO data. So is it acceptable to use these electronic mechanisms as they're doing? So they're looking for 400 patients total, ages 18 to 39. So they're actually young adults. And they are enrolled into the trial and then sent PRO questionnaires at intervals during their therapy at baseline 1 month, 3 months, 6 months, and 12. There are lots of sites approved to enroll, 292 total. The majority of accruals, as might be expected, are through ECOG Akron, but there aren't any SWOG accruals yet. And so I just wanted to mention this trial again, because it's good. It's, telling us a lot that we need to know about the subjective experience of AYAs going through cancer therapy. Again, it's going through the NCORE network. And all that the home site needs to do is to screen and consent and register. And once the patient is going and on the trial, the study team actually contacts the patient and does all of the rest of the work. So I would be happy if we could get some SWOG sites as part of this. I think it would be important data to collect. And again, John Saltzman is the chair of that, and I'm happy to take questions if anyone has any as well. Anything else on that? So this is a public service announcement. Another piece of great news that on the CTEP website, there's now a really easy to access tab that you can look right where the down here where this red arrow is. So there's the trial portfolios by disease. And it used to be that to find the AYA related trials, you had to go in by disease site. And there was also an AYA portal that was kind of clunky. People had a little trouble getting into it. It didn't include heme malignancies, but now there's this tab that is just freely accessible on the website. And when you click it, it shows you this information on the right, which is all of the open trials by disease type, color-coded for newly diagnosed or recurrent disease. And on if you click on any of these, it'll give you obviously all the information about that trial. And there's another tab that's easy to get to that shows them all on a list if you prefer that to this graphic format. So if you have an AYA patient and you're wondering if there's an open AYA trial for them, it's now super easy to find out that information, and this is updated frequently. And then the last thing I just wanted to update you about, and hopefully get some thoughts from the audience over just a few minutes is a project that we talked about during the pandemic when we were all fully remote, which was the initiative to create a website to connect SWOG investigators more easily within the NCTN, given that none of the cooperative groups have any sort of public listing of their membership. And so it can be hard unless you're already in, SARC or the leukemia group, and you already know all your collaborators. If you're thinking about something and want to find people who are doing relevant research in other cooperative groups, it can be hard to find them because, we're at the SWOG meeting and other people at their meetings. And so it's just not information that's published anywhere. So we had gotten a in-kind support offer from this Slalom consulting firm who was going to help us have a password protected website where people could sign in, and it would be this AYA Oncology Research Hub. And you could look by disease type and also for, particular types of research like fertility preservation or survivorship. Or you could perhaps look by NCTN group as well, if you want someone from ECOG Akron who does testicular cancer research, et cetera. The consultant suggested a bunch of other things like, oh, maybe we could pull in all the relevant publications. I don't know that we need all that. After they finished with their pro bono consulting hours, the project wasn't finished. And so they said we could do it for $20,000 extra. So that's where we are now, but they have written a bunch of code. And so I was on a SWOG call one time with Dr. Blanky and, a bunch of others, and he said something which piqued my interest, which is that, well, we all need to get this body of information and maybe we'll just put it on a password protected Google document and do that. And so I wondered, well, could we just do that for this? And so I wanted to get people's thoughts because I think that we could probably do that in a half an hour, make an easy password, share it with everyone. And, y'all could share it through your groups where you're routinely talking to other NCTN members, and we can let people know that. And that would be a really bare bones version of this, like, Hodgkin's disease, researchers interested, their email, their phone number, their specific project, something like that. And on a website such as that, everyone would have editing privileges, but it would be, who would mess with it, right? It would probably be just for a small group of investigators who wanted to know that information. So what do you guys think? Would it be worth $20,000 if we could get it to have a prettier looking website? Probably not an app, I'm thinking, because why would you want that on your phone? But would a website be better? Would a password protected document living somewhere be adequate? Do people want that information? Ideas?
I would prefer a website.
A website?
Yeah,
Mhm.
without like a Google document password protected Google document. I don't think it's gonna work
Because
it's harder to find.
Mhm.
It's not publicly available. If you're in the clinic, you have to go back to the link of that Google document.
you would have to
like,
find
yeah.
the link. But what if, for example, Team Cancer America had the link on their website and you
Yeah.
could grab the link from their website, but you would have to know the password?
Correct. Like that could also
Could
work.
work. It would, if there's a website and maybe even with a Google Doc, there would need to be an occasional curation of the material to make sure that nothing was getting majorly screwed up. And Teen Cancer America has actually volunteered to do that. So they will put whatever we ask onto their website and give it a little, look every month or couple of weeks, whatever that requires. So either one could work, but the question is how fancy we need the site to be. And again, would people still want that information, or has in fact the communication progressed to the point where everyone can find the co-investigators that they want from the other cooperative groups?
Make a suggestion?
Yeah.
So there's often a lot of times like collegiate groups, right?
Mhm.
Web designers that are looking for projects like this. So that would do this probably pro bono, right? So I think you could, maybe there's a compromise, right?
Mhm.
Something better than password protected doc, which also has security issues, but would provide what you need, but not for 20 grand.
Yes.
Just and unrelated to how it's developed, but where it lives sounds great. At first I was thinking that the collaborations are really being robust and sort of ongoing. But I think for YIs, this might be a really nice resource.
To get themselves out there. Yeah.
Just to sort of know what's out there, potentially, and especially if it's a total space where everyone can access it.
Cool. So still relevant.
And I think especially for AYA, because it's so transversal, like
Mhm.
it's so involves so many different
Yeah.
cancer types. I think it's like
Still
needed.
useful.
Yeah, I think it's
so
gonna be,
cross-cutting.
yeah.
Yeah. Okay. Great. Thank you guys for your input. And so we'll continue working on the website because it sounds like that might still be preferable. And I'm optimistic we could get funding from somewhere, and it's not that much. It just needs to be finished and or redone in a simple way. While I'm standing up here, I'm going to make a quick plug for the upcoming Global AYA Cancer Congress, which is in Long Beach, California. It rotates between Australia, Great Britain, and here. And it's the week of June 20th, like Tuesday through Friday. And there's a meeting one day of the new AYA Cancer Association. So should be fun. And it does really do a great job of getting people interested in AYA all together at once. All right. And with that, we will go to Dr. Boschman for the Talk to Me project. And Allison Rosen.
Hello, I'm Melissa Boschman. This is Allison Rosen. We are going to present on behalf of our study team. We're here today, and also I just have to say it's really nice to be here. Thank you so much. And it's nice. I come from SWOG. I'm not from like another planet. But it's really nice to be here and hear the same types of conversations that we have at the Children's Oncology Group meeting. So anyway, it's just glad to be here. So we're going to talk today about our study. So our study team is Dr. Hillier, who I think is on the line. She's an epidemiologist at Columbia. Myself, Justine Kahn, who's a pediatric oncologist. Desiree Walker, who, yay, hi, I haven't seen you in person yet, who's a patient advocate and many other things, and we've collaborated for some time. And then Allison Rosen, of course, who's a SWOG AYA patient advocate, and then Maria Fraser, who's our COG AYA patient advocate. So I think we're probably preaching to the choir with this, but we know that AYA participation in cancer clinical trials is low, and of particular concern is the disproportionately lower rates among certain AYA populations, including racial or ethnic minority populations, people who speak languages other than English, et cetera. This may be due to many factors. We know that there are multi-level factors that are barriers to clinical trial participation at the system level, at the institutional level, at the provider level. But we also know that these may be due to some unique health beliefs and informational needs among AYAs. And so one way to think about this, there was a recent publication by Abreu et al. Published in Pediatric Blood and Cancer, where they conducted qualitative interviews and identified 3 themes that were sort of explained the barriers to clinical trial enrollment that were financial, educational, and psychological barriers. And so for AYAs, we know that social media and the internet are the primary sources of health information. And so we've proposed this project that we're really excited to be, it's ongoing. And the goal of this project, which is tailored AYA trial messaging, is to design an intervention focused on increasing clinical trial enrollment among AYA groups between the ages of 18 to 39, so really YAs, that are underrepresented in trials. And our hypothesis is that for diverse AYAs, a culturally responsive, developmentally appropriate, and disease-specific social media campaign that uses tailoring of messaging could significantly impact perceptions of, attitudes toward, and willingness to engage in discussions about clinical trials. So our approach leverages a multidisciplinary team. We have clinicians, researchers, and advocates. We've really partnered with the patient advocates, and Allison's going to talk in just a minute, to understand AYA experiences, insights, as well as our AYA advocate partners have broad reach into the community. And so we're trying to utilize these networks for message development, evaluation, and dissemination. We also have inclusion of diverse team members with the goal to more effectively reach diverse audiences.
So I'm going to talk to you about our aims, and I think we're on aim 1 essentially right now, and there'll be an ask at the end of this, and we'd love your help with it. So first aim is to partner with SWOG and COG AYA advocates. We have a list of high priority topics that have been developed through research. We have some topics that we have as a group developed as far as we were just talking about financial, educational, psychosocial barriers that patients have traditionally identified for clinical trial enrollment and why they don't enroll in clinical trials. And so now we want to form focus groups. So through the advocates, we have reached out to our communities far and wide, and we're going to have some focus groups, and we're going to have representation from rural areas. We're going to have different age groups. So we want to make sure we're representing the teens, 20s, 30s, rural, urban, ethnic variety, like so many different populations. So, you know, I think the 3 advocates that are on it, we're a great representation of diversity, but we want to make sure we have what we've created, and we have many opinions as far as make sure we're picking the top barriers that they find that is why there's not diversity in clinical trial enrollment. So develop and implement a checklist of criteria, rank and select topics using the Delphi method. That's sort of aim 1. Aim 2, which I'm really excited about, co-design and co-develop messaging and materials targeted to these high priority topics that are identified in the focus groups. So using future workshop methodology in which participants critique existing materials and contribute to the creation of the intervention. So you're sort of seeing a theme here that AYAs are going to be involved from the very beginning. And we've heard of you talk so far that sometimes advocates are involved in the end, sometimes in the middle. We really are making sure that AYAs are involved at the very beginning, middle, end, throughout the whole process. And we're reaching within our community. So it's not just a few, it's a lot of people that are looking to make sure we have the messaging and the materials correct so that we're going to reach the right populations. And lastly, strategically select, evaluate social media platforms. So we heard from Mark Lewis in the digital engagement that where are the AYAs? Where are people using social media? It's not necessarily Twitter. It is going to be Instagram. It's going to be TikTok. It's going to be Snapchat. It's going to be places where we're going where the AYAs are, not where we necessarily are. So the AYA advocate partners, we're going to help guide the messages. So we have the main topics. We have the materials. Now, what platforms can we help disseminate them on? So the idea is to be on Instagram, TikTok, Facebook, and Facebook might even be advocates using ourselves, but also our advocate partners to put in Facebook groups, because Facebook is great. AYAs are there, but they're mainly in specific cancer groups that they're a part of. And of course, with social media, hashtags, we're going to do stories, reels. I'm super passionate about this because I use social media often to educate about different things related to cancer in the AYA space. Content will be posted daily, featured rotation of posts using the framework that includes informational, personal, humorous. We definitely with AYAs want to have humor in it because we don't want to just give facts out there. Clinical trials. We want to make sure that we're using real stories, real people, and making sure that we're getting their attention. It's not just some fact on a post that they can read. Memes are a great way to do this as well. We've seen this through the cancer patient on Instagram. I think he has like 90,000 plus followers. He's a good friend of mine, and he's done amazing work with reaching the AYA populations as an AYA himself. So that's sort of our aim 3. There's one more part to that. I'll let you.
So then, of course, we want to evaluate what we're doing. Aims 1 and 2 will really be sort of a qualitative assessment, iterative approach. But for aim 3, we'll be able to gather some quantitative data as well. So we'll measure our campaign reach and identify optimal modes of communication to scale our approach for future, hopefully to scale this outside of just this 1-year pilot study. And so we'll measure engagement, looking at followers, likes, comments, and shares. We'll look at impressions and reach, how many times a post shows up in someone's timeline, how many unique viewers do they have. We'll look at share of voice, how much of the online sphere is our presence representing, and then response rate and time. So we'll track our ability to respond to communication and how long that takes. So really look at what messages are coming back and what questions are coming back, and how are we able to respond to that in real time. And so to date, we have IRB approval. We've had bi-weekly team meetings. It's really been such a wonderful collaborative effort, or at least from my perspective, it has. And so obviously we've identified our AYA stakeholders and advocate team. So we have representation from the cooperative group perspectives, specifically for the purposes of this at this time, SWOG and SWOG. We've identified key information from our AYA partners, incorporated them into the study. And now AIM-1, we will have our focus groups. We've been recruiting, really, as Allison said, through many networks. And we actually have our first 2 focus groups scheduled, so we're very excited for the end of May. And we actually may need to break one into 2 focus groups because our group is quite large, which is exciting. We're excited to see the enthusiasm. And then we will develop our topic ranking checklist to inform our message co-design for AIMS 2 and 3 that will be informed from our focus group updates.
Okay, yeah, so here is our ask. We have focus groups forming. We have 2 coming up on the 22nd, I think, and on the 30th. This lovely QR code. If you are an AYA yourself, or you know AYA patients that are active on social media or are very opinionated in a very good way about clinical trials or just treatment in general, if they're active on social media and have an opinion and share that on social media, we want them to be a part of this. We want as many voices in many areas that we can possibly get. So, I mean, I'm not going to read all this. Basically, young adults previously diagnosed with cancer, 18 to 39, confidentiality. Yeah.
Question on that. Previously diagnosed with cancer, so on active treatment, okay, survivors only.
I think we're okay with on. I think it's up to, yeah. So we're not some clinical trials, A, B, C, D. We really want, they can be in treatment right now. I think we're looking for somebody that's not like 20 years out, they might not have as much, but even like I'm a 10-year survivor, but I'm very active on social media. I'm very in tune. So we just want people that are active and in tune with AYAs and social media and stuff. They're 2-hour-long focus groups. There's a gift card. We're always going to compensate. This might be the first time they're helping with figuring out the barriers. Then we might invite them back to look at some of these marketing materials, like we said. So it's an extension of our larger group. So they're not just going to be one and done. We hope to continue engaging in them. And so we have 2 scheduled in May already, but again, anyone that might be interested in joining those, we might have to break them up. We might go a little bit later, maybe in June as well, but we're making day and evening. Some AYAs are okay during the day. Some work and can't. So we're being very, very flexible, and it's via Zoom, so they don't have to come anywhere. So that is our ask. And we're really, really excited about this. We've heard, social media is something I'm super passionate about. The whole group is very passionate about. And I think we have a unique opportunity here to reach populations that we wouldn't otherwise be able to reach in a unique way, because nowadays I'm on TikTok. Everybody is on some social media platform, and kids, young adults are definitely on a social media platform. If they have anything, it might be a phone or social media versus a TV at home, which is sad, but is the case with many. And I think.
So did you guys reach out to a patient, cancer specific group on social media, like Testis Cancer Canada, Testis Cancer US? Like I'm sure like there are like for all kind of type. Of cancer.
So we have in the patient advocate group that we have here at SWOG, all of us advocates created a list of different AYA groups at one point. I can't remember when we did this, but we had a list of all these nonprofits. And so why all of us advocates are involved in a lot of these groups. So where I always ask permission. Obviously, I'm not just going to post as, hey, will you be in this focus group? So I always ask the people permission. So we've posted in things like First Descent has an alumni group. So that's all cancers. Stupid Cancer has a group. I have gone specific in some of the cancer groups I'm involved in, AYA and colorectal cancer specific. And then I also have reached out to some of my friends who I know are very, very active on social, and Maria and Desiree have done the same. So we've reached out within our wide networks. There's some overlap, but there's not that much. So we probably could do a little bit more. And so if there are any groups that you know about as well, feel free to come when you stay after and tell us. And if we haven't reached out to them, the advocates will happily post this information in that group to recruit more.
Yeah, no, there are definitely a lot. I am part of some of them, and like a lot of new diagnosed patients who are going to start on treatment pause there. So I think you should definitely reach out.
Yeah.
Because like this is the first thing that they do.
Yeah.
They
Yeah.
reach out.
Yeah. So we'll get those
Yeah.
information from you.
Absolutely.
And is it clear yet? I'm sorry. Is it clear yet what your output will be, or is that iterative based on what the focus groups say? Like, will it be videos? Will it be posts?
I mean,
pictures?
I think they're asking us advocates that are on the group, and we probably will. I mean, I know just based on social media that reels are very, very popular now in Instagram. So it's what's trending. We definitely will do some static posts for sure, but what is trending right now in social media? What is popular? It is the reels. If it even is pointing, there might be some dancing, there might be some humor, there might be some memes. So I think we're going to do a combination. And like Melissa was saying, we're going to see what does the best. So whatever does the best, we're going to probably make more or push those out. So we really it will change over time.
If I may too, so when we first started this, I think we were a bit of social media dinosaurs. And I remember we were like, okay, we're gonna make clips, we're gonna make videos, and we thought maybe a couple of minutes, we wanted to keep them short. And then we were talking with Allison and Desiree and Maria, and we were like, okay, we're gonna do TikTok videos. And so we've been educated. It's been really an interesting and exciting experience because you have to make the right messaging that's going to reach the patients that you're trying to reach. But yeah, it's in the beginning, we thought we were going to have a different output, I think, than we think now, which it's been fun to see.
Yeah, I was at a meeting recently and people were talking about clinical trial videos that are like 7 minutes long. These aren't going to be, none of this information is going to be 7 minutes long. The average TikTok I make maybe is about 10 or so seconds. And then that starts a conversation in the comments with questions. And then you answer those questions in another TikTok and same, it's just like a spiral. Same with, I think, we haven't necessarily talked too much about it, but maybe even lives on Instagram and TikTok, because I've dove in a little bit more with that as far as myself, but also like a healthcare partner being on it with. So I can answer questions related to experience, and then a physician or healthcare worker can answer about, the science behind it. So.
And then I think my interest is always in implementation science and thinking about how we measure this. And as we start to roll these out, what is the requirement as far as the personnel and who's looking at this, who's responding, how much time does it take? Is it feasible? And so those are the things sort of in that last outcome that we'll be looking at.
I also have another comment. So when you do this kind of marketing for business using social media, the outcome that you measure at the end after your investment is how much revenue you do, like with investment. In clinical trials, this is like very hard to measure. So I know that you're going to measure like views and comments and how many times they will share the story, etc. But ultimately, what we want is that these patients participate more to clinical trials. So is there any mechanism that you envision could be linked to this strategy in order to measure that?
Yeah,
we've talked about doing polls and just asking for how likely are you to talk with your provider about clinical trials, because right at the end of the day, they may not be eligible. There may be a different other level barrier in the way, but at least were they able to bring that up or have that conversation, someone bring it up with them. And so we've talked a little bit about that. I'm hoping that during the focus groups, we'll get some more information on that. It's a very important point. The end outcome of enrollment on clinical trials is always so tricky, and it's
Oh, I think she's had her hand raised.
The QR code just goes straight to a form. You have something like a website or anything that just tells you a little bit about what you're. For?
That's a very good point. So yes, that's right. So it goes to the intake form, which is essentially some information. So this QR code should go to an AY who's interested in potentially participating, and then we capture some basic information, then we would contact them back.
Right.
This slide has the information that should perhaps be on a page that you would go to. Thank you. It's very helpful feedback.
And there's another question.
Yeah, another couple.
Oh, sorry. Yeah.
I was just wondering, are you gonna have disease specific kind of reels? Because what in a small support group that I run for in my little area of the world, but they really are they're one of the needs. They always say like they don't want to just talk to random other AYAs that have cancer. They want to talk to AYAs that relate to what they are going through at that moment. So and then thinking like when they might, like where in their path. So if they're diagnosed, right, depending on what type of cancer they have, they might be in the hospital or outside of the hospital. But if they're in the hospital, like the opportunity for clinical trial might be before they're going to be looking up social media stuff. Right, because they're like at least in the
Right, if they're diagnosed with leukemia, right, and they're in the hospital, and then they're looking a week later, and they're like, "Oh my gosh, I should have thought about a clinical trial."
Right, and I mean, most people, if hopefully they're getting exposed by the provider, but let's say they're not. But so how do you do that? Because by the time they kind of come out of this haze and start wanting to look on social media about their cancer, their treatment may or may not be started, and so that's gone. That opportunity is gone.
So
Unless they're recommending to other cancer friends, like, oh, you should do that.
Right.
You know what I mean? Like, how do you capture them very early? Because it's a very early on thing that they, things move quick as you guys.
I'll say from an AY standpoint, that's not all, but like when I was diagnosed, I went to Google, I went to social media. I was lurking, like was talked about earlier, I was looking around. So when you use hashtags, so even if you use cancer, cancer patient, cancer survivor, cancer thriver, cancer research, you use a lot of hashtags, it will, if they're searching for a specific hashtag, the idea is to have these hopefully go viral or be very popular. So that maybe when they're in the hospital or they're, diagnosed and they're looking, craving information, that they will not go to Google necessarily, but they will go to social media where they would anyway. They look up a hashtag that we've used, and we're going to look up some of the most popular ones that are cancer related. And they could have, a lot of times when I do posts that are AWA related, I use the hashtags for all different cancers. So I don't exclude anybody. I want to make sure even the rare cancers and all these different things are there. I would say that, the goal is to be as organic, not organic, but really if they're on social media and they happen to look something up, then this will sort of pop up as well for them to see. So, when you're talking about a blue dress and then you go to your email and then boom, there's an ad for a blue dress. Like the idea with TikTok, for some reason, you're talking about things or you're looking one thing up. Now my feed on TikTok is cancer related, but also cats, because I love cats. So I see both sets of videos. I mean, really the algorithm behind, a lot of these socials is if you use the right hashtags and, it targets without you having to, besides the hashtags. Yeah. So
I guess the one, I mean, again, just thinking this through like in a live encounter, the people who the family and their friends are more likely to be doing that in real time because this patient is reeling and they're not that's just my experience. They're either sick and they're not looking on social media like that for that, but their family and friends are. So I don't know if that would be something you could try to capture, like who's doing it. Is it the family and friends, the thing? Because that's who, again, I kind of in a real life scenario, they're the ones who usually will ask those questions before the patient will.
Right. No, I think, and we've talked about this a bit of how do you categorize the types of messaging, especially thinking about like acuity of presentation or even just tumor type. I think, as a pilot, this is our first step into it. I'm hoping that some of the feedback we'll get in the comments and our tracking measures, you'll be able to tell some of that information, whether it's quantitatively, probably not, but maybe qualitatively. But it's certainly an important point. I think one of the other things is even just raising awareness in the AYA community about clinical trials, right? It's hopefully going to be a secondary goal of this. But it's certainly a point well taken.
One more.
Excellent question. Melissa, I'm just running.
All of the questions, can you just go to the microphone, you have my line on it?
Okay.
Thank you, Eric.
So I was just running through a list of patients in my head that might be interested in this. There, Melissa, from Columbia, I'm thinking of a young woman who went on to a SWOG NCTN clinical trial, a medical student as well. Would she be of someone that you would want to talk to? Okay.
Enter this QR code.
Okay, perfect. I'm just curious.
No, that's great.
Yeah, she has a large social media following. She even donated the chemotherapy belt to our research infusion center as well.
Awesome.
Okay.
Thanks, Eric.
Send all and any people our way.
And even if our focus groups, if we fill them up too quickly, we're going to have an ongoing need because this again is an iterative approach as we develop the messages. That's
Yeah. Any other questions?
Thank you very much.
Thank you.
Thank you so much. Oh, and thank you to the Hope Foundation, in particular, as well as SWOG and SWOG and all of the others, but we're very grateful to have this opportunity.
All right. Now we've got Dr. Danishman, who looks like he is on the Zoom.
All right, everybody. Hi, Sia Donishman here. And thank you very much for this invitation. I'm sorry I couldn't be there tonight, but I'll be there Saturday for the GE committee meeting. I presume Lucia is there, and I want to thank you for the invitation to present the clinical trials for early metastatic germ cell tumors, specifically our work in seminomas and sort of what's coming down the pipeline here for us. So my disclosures are non-relevant, really. I'm just on the AUA Guidelines Committee for Testis Cancer. I'm from USC in Los Angeles, the Keck Medical Center, small city in Southern California, as you may have heard. All right, so management of stage 2A seminomas really hasn't changed much in a number of decades, actually. This is the latest version of the NCCN guidelines, but it's reiterating the same thing year after year, which is primary treatment includes radiation therapy to include the periaortic and ipsilateral iliac lymph nodes to 30 gray, or primary chemotherapy, BEP times 3 or EP times 4. And then for stage 2B disease, it's primary chemo, again, BEP times 3 or EP times 4, or radiation therapy in select non-bulky cases, and non-bulky is defined as being less than 3 centimeters. And this again includes the periaortic and ipsilateral iliac lymph nodes to a dose of 36 gray. So again, these haven't changed. The cure rates are very good using both of these modalities, but there's long-term morbidity from both chemotherapy and radiation. And those who relapse end up getting dual treatment, and the morbidity is sort of additive in that setting. These are young patients. They've got excellent cure rates. They've got decades, really, of potential cumulative toxicities that increase with time, as we know from the number of longitudinal studies done in this area. And as you all know, there's cardiac events, secondary cancers, both hematological as well as solid cancers. And we're seeing some of those patients now decades out from primary radiation that have been cured of their seminoma. And we're seeing them years out. And for their secondary malignancy, we go back in the retroperitoneum surgically and sort of feel that radiation back there and the effects it has had, even though it's considered sort of lower dose than other malignancies that we treat. Then there's, metabolic syndromes with chemotherapy and bleo-induced pulmonary injury, although that's not very common. But certainly effects on fertility, neurotoxicity, tinnitus, and things like that can be bothersome to the patient. And there's now evidence that long-term hearing is affected with high-frequency hearing loss in many of these patients with cisplatin-based chemotherapy. So is there a treatment that can reduce the long-term morbidity, still offer a cure for these patients? And well, the answer is yeah. I mean, RPLND has been around for a long time for stage 1 and stage 2 non-seminomas. I started looking at RPLNDs as a primary treatment for low volume metastatic seminomas quite a while ago. This was over 10 years ago now, and sort of published a small series in clinical GU cancer, looking at 4 patients who underwent RPLND. This is primary RPLND for metastatic seminoma. The lymph nodes were fairly small, 1.1 to 1.8, except for one patient who had a 5.5 centimeter tumor, and we just could not diagnose the cancer. We just went in and did a resection, found out that this was all pure seminoma with a burnt out primary. And all 4 of these patients did very, very well. The mean length of stay was 3 days. There was one grade 1 complication of ileus, all maintained antegrade ejaculation. No one got adjuvant therapy. And there were no recurrences at the time of this publication in 2015 with a mean follow-up of 2 years. But I can tell you that I followed these 4 patients out, and the first patient is now 11 years out from surgery and without any recurrence. So very encouraging primary preliminary results. And you look at the literature, and there were only 11 cases published with similar results with no recurrences. But really, in order to move the needle forward, I think you need to do a prospective trial, multi-institutional, kind of prove that this works in a larger sort of setting. And that's what we did. This was the SEMS trial, the multi-institutional phase 2 surgery in early metastatic seminoma. This was sort of funded through a philanthropic fund from one of my patients, but each institution sort of took on their own sort of financial responsibility. This was a surgical trial, so not that expensive in terms of cost. It was just sort of gathering the data. So the treatment was to undergo a modified template RPLND. It had to be open because we didn't want to introduce any additional variables in terms of robotic surgery. Primary outcome was 2-year recurrence-free survival, with secondary outcomes. You can see there the 5-year RFS, pathological upstaging, treatment-free survival, and complications from surgery, both short-term and longer-term. So the target accrual initially was actually 46 patients, and we were accruing quite well, and we wanted to increase the N for more generalizability and allow some of the other sites to come on. Multi-institutional, we had 15 sites activated with 12 accruing, sort of nice distribution across the US, and one site in Canada. That would be Lucia's site at the Vancouver UBC. So these are all the collaborators, the surgeons and medical oncologists who helped accrue to this trial. And you can see that we did pretty well in terms of accrual. In the blue, you see the actual accrual and the anticipated. Towards the end, as more and more sites came on, we had rapid accrual over the last year of the study. So we did quite well. And the major accruers were Indiana University and our site and Mayo Clinic. And you can see the other institutions there. Data maturation, you think this is a simple trial and you either relapse or you don't, and you have chemo and things are simple, but nothing's ever simple when you do a trial. We did use metadata rave, which helped a lot in acquisition of data. Surgical trials are different than medical oncology trials, and even the bladder sort of intravesical agent trials that we run. There's a lot of other variables that we don't think about routinely, like templates of surgery, number of lymph nodes. There's CT scans in terms of lymph node size and things like that we need to look for. So we really looked for that fidelity between clinical events and our database, went over it over and over and over again, because this is a small number of patients overall, and any sort of alteration makes a difference. Who's entering the data mattered. There are people who don't understand the terminology, retrograde ejaculation, what that means, and fertility and things like that. So again, a lot of phone calls and a back and forth to the PIs, and again, back to the patients to really get the source data and make sure they're accurate. So we feel really good about the fidelity of the data. But so here it is, 55 patients, median age was 34 as expected for seminomas, most of them being Caucasian, very healthy population. And the initial clinical stage, this importantly, so a quarter of the patients were stage 1 who had recurrence, and 75% of the patients just presented with stage 2A or B at at presentation. The median follow-up that should be actually 33 months at the time of publication. This was an earlier slide, so I'll show you that. So one of the things that I've been doing for the past decade or so is this midline extraperitoneal RPLND, same exact exposure you can see on the left side to both the great vessels on the right and left. We completely skeletonize everything, nerve sparing, sparing the L3, L4 postganglionic sympathetic nerve. But the difference is smaller midline incisions. The patients are going home the next day. This is not what many remember as a very morbid operation. With large stem to sternum incisions and 5 to 7 day hospital stays with NG tubes and things like that. So this really kind of puts things into perspective, because when you're offering this treatment option, the patients are thinking, oh man, 7 day hospital stay, NG tubes, 6 to 8 week recovery and things like that. Well, when you offer this sort of smaller incision, home the next day, 2 to 3 week recovery, it starts to look very different. For the patients. If there are any surgeons in the audience, you'd appreciate the extraperitoneal technique where the bowels are not exposed, but the exposure to the retroperitoneum is exactly the same. And we've described our technique via short videos, and we have an update, and now we're updating our series with over 200 patients with this extraperitoneal technique. And this applies to both primary as well as post-chemotherapy patients as well. So here's the actual publication. It was published 2 months ago in JCO with all the collaborators. Again, 55 patients. The median follow-up was 33 months at the time of data cutoff. We had 12 recurrences, and you can see that recurrences are happening fairly early, with most patients having recurred by 2 years. So we were correct to sort of anticipate that 2-year RFS was going to be the adequate sort of time period. But again, median follow-up here, 33 months. You can see our confidence interval there. So of these 12 patients, 10 were treated with chemotherapy, and 2 actually underwent additional surgery for cure. And those 2 patients remained systemic treatment free. So importantly, overall survival rate remains 100% for these patients, because as we know, these are good risk patients, and we can salvage the relapses with chemotherapy. So this is a graph looking at treatment-free survival. And again, the 10 that were treated with chemotherapy, it should have really been 10 BEP times 3, but we have 8 of them who had BEP times 3, 1 EP times 4, and for some reason, 1 underwent carbotopicide. And as I mentioned, 2 patients underwent further surgical resection. One of them was my own patient. He really wanted to avoid chemotherapy, sort of twisted my arm into going after a relatively indolent node that was actually in field, that was growing fairly slowly. I waited to make sure he doesn't have further metastases, and I sort of went back in, and it was not a difficult operation, having had a prior extraperitoneal operation. So the second time around, I went transperitoneal. All the other lymph nodes were done. I just had to go after that one. And he remains disease-free 7 years after surgery. There was one patient who received adjuvant carboplatin for upstaging from 2A to 2B, but for the other 54 patients, nobody underwent adjuvant chemotherapy. The complications are seen here. These are graded by the surgical Clavien-Dindo grading system, minimal incisional issue, and a couple of patients had ileus. One patient had ileus and a pulmonary embolism, and one patient had chylosocites. For the long term, which we deemed anything after 30 days, there was one incisional hernia that was radiographic only and not symptomatic. And then 3 patients had anejaculation, but all 3 underwent non-nerve sparing operations. The patients didn't request a nerve sparing operation for whatever reason. So overall, really low complication rate, as seen in other modern trials as well. So there another trial called the PRIME test, and in comparison to the SEMS, very, very similar. This was done by Peter Albers at Dusseldorf in Germany. This was also a phase 2. Their inclusion criteria was a bit more wide, included inguinal and retroperitoneal lymph nodes. They allowed lymph node metastases up to 5 centimeters, whereas for our trial it was 3 centimeters. And they did allow patients who had received a single dose of carboplatin for stage 1 seminoma, whereas we did not allow any prior treatment because we wanted it again to be a very homogeneous cohort and make sure that we don't introduce other variables. In any case, very, very similar primary endpoints. Ours was 2-year RFS, theirs was 3-year PFS with the secondary endpoints you can see there. That was a single institution. Ours was the multi-institutional. This was actually published just recently as well in European Urology. It's unfortunate that there's a picture of a scrotum on the cover of that issue, but but these are the baseline characteristics of the patient. One of the differences also was that 19 of the 37 patients underwent robotic surgery, which is one of those controversial topics of open versus robotic for stage 2 disease. And there's ongoing debate because, again, you're introducing another variable in a prospective clinical trial. In any case, that was allowed. And you can see the recurrences here. They did have 10 recurrences. There were 3 in-field recurrences and 7 out-of-field recurrences. And you can see time to recurrence for the most part, again, is early. So when we do this operation, if they're going to recur, most of the time it's early. They just had 1 out-of-field recurrence at 36 months. Otherwise, the rest of them were early. So the progression-free survival for their trial was 70% after median follow-up of 32 months. Again, recall ours was 80. Or 78%, 22% of the patients had a recurrence. So similar. There is a third trial, actually another trial as well. So the COTRIM study is very, very similar to ours. This is the Cologne trial of primary RPLND. So Cologne is in Germany, and Axel Heidenreich, who's the chair at University of Cologne, is running this trial. So they presented at GU ASCO 21 patients with 21-month follow-up, relapse rate of 9.8%, and again, 100% survival for them. So now you can see sort of an emerging pattern with close to over 100 patients now, with the relapse rate being, if you combine the series, again, there's some differences among them, but if you combine it, the relapse rate of about 15%. And that's been our experience outside the trial as well. So I didn't stop doing this operation once the trial ended. I have continued to do it ever since that. So we have a lot of patients outside the trial undergoing surgery, and our relapse rate at USC is approximately 10%. So very similar to the Cologne experience. We continue to do them open through that midline extraperitoneal technique, like I told you. So I think SEMS and the other trials really establish RPLND as a treatment alternative for testicular seminoma with isolated retroperitoneal lymphadenopathy, less than 3 centimeters. There's some that we've done that are a little bit bigger than that, provided this is just a single node. I think once you start to look at more than 2 or 3 nodes, on CT scan, really, when you do the surgery, it turns out to be 15 nodes because many of them are microscopic. Good median follow-up. I can tell you that since the publication, our median follow-up is actually close to 5 years now, and I have not seen any further recurrences. We'll see what the data cut is for the next iteration of this with longer follow-up. But to my knowledge, I don't think we've seen any further recurrences or relapses. So systemic treatment-free survival, again, at 82%, the vast majority of patients are being spared the toxicities of chemotherapy and radiotherapy in the long term. So it is an attractive option. There's hopefully not any long-term morbidity of RPLND. We're not going to see anything happening in 20, 30 years. We know that already because we've been doing this operation for that very, very long time. So the other important thing that I didn't put in here just for time purposes, go into the details of the study, is about 10 to 15% of patients will actually have PN0. So they will have clinical nodes on radiographic assessment, but no nodal involvement during surgery. These are the same patients who are undergoing BEP ×3 or radiation therapy to a proposed lymph node that's positive because biopsies are not routinely done. So again, surgery, I think, will categorize the patients into the correct sort of stage, those patients obviously don't need any further therapy and probably very little in terms of subsequent imaging. So I think everything's going to change pretty soon, thanks to Lucia and everybody else around the world who's working on microRNA 371. This is a very, very highly sensitive and specific biomarker for germ cell tumors. And it's stage dependent, meaning it's quantitative, and you can see higher levels of microRNA 371 A/3P with increasing stage. And this is a publication from Diekmann in Germany, published in 2017. And you can see that after surgery, prior to chemotherapy, the levels are high, and right after the first cycle of chemotherapy, many of the patients, the levels will go down. So this is something just like the traditional tumor markers you can actually follow. And Lucia has done a lot of work with this and published a number of papers on microRNA 371 and its expression across the spectrum of disease states, and the false positivity is quite low and the false negativity is quite low. And if you look at the operating characteristics with several of these publications, 3 of which are retrospective and 2 are prospective, including Lucia's study there, you can see the sensitivity is 90 to close to 100% in some of the studies, with specificity ranging from 80 to, again, 100% in some of the studies. So very high negative as well as a positive predictive value, yielding an ROC in the 0.95, 0.96. These are not curves, these are straight lines that go up. So, with this decades worth of work in microRNA 371 and SEMS, you can imagine we should be ready for a prospective clinical trial in this setting. So there is the SWOG S1823 study, as well as the AGCT 1531 that's looking at collecting the microRNA for 1,000 patients in S1823. There'll be a abstract presented at ASCO next month on this, with just trials in progress sort of poster. And these are blinded to both the patients as well as the investigators. The serum is collected on all stages of disease post orchiectomy, and then it correlated to the stage of disease later. So we're looking at I think we have about 600, which you can correct me if I'm wrong. So this is accruing quite well.
Yeah.
700, perfect. So yeah, we're doing great, and hopefully we'll learn a lot about the real-time operating characteristics of this in a prospectively run manner. But I think the next step is how are we going to act on this? This is double-blinded right now. We don't know the results. We don't act on it. So these are the 2 trials, about 1,000 patients for this S1823. The AGCT is actually a multi-centered open label clinical trial with 5 different arms of various chemotherapies and active surveillance. Enrollment is 2,000 patients, and expected completion would be somewhere in 2027, I think, or probably maybe even later than that. So that one's a little bit different. I'm not sure what the accrual is there. So this is our concept, developed by myself, Craig Nichols, Lucia, Christian Kohlmensberger, and my fellow Mohamed Al-Siouf. Now we're broadening this to stage 2 germ cell tumor patients. These are patients suspected regional disease. The stratification is less than 3 centimeters or more than 3 centimeters. Again, staying to that same concept in SEMS, and looking at microRNA 371 in real time. If it's positive, the patients go to primary RP-LND, as we did in SEMS. This is both for seminomas and non-seminomas. But I told you, that about 10 or 15% of patients, up to 20%, will have a 2-centimeter lymph node, 1.5-centimeter lymph node that's actually negative. We do an RPLND and there's no germ cell tumor. We're hoping to capture those patients with the microRNA 371. If the 371 is negative, we will observe the patient and reassess at around 6 weeks with further both traditional tumor marker CT and another microRNA 371. If everything continues to be stable and marker microRNA negative, then we will continue observing the patient. If your tumor is more than 3 centimeters, we're just going to draw the 371 and then either get BEP or rarely some of the patients are going to get surgery. So very few false positives in clinical assessment in patients who have more than 3-centimeter nodes. So I think standard of care there would be just to go to chemotherapy for those patients for the most part. So this is what the actual trial looks like right now. microRNA detecting active germ cell tumors in early suspected and metastatic disease called the Majestic trial. Just a little bit more detail from what I just told you. All those boxes to the right are basically just follow up, and the primary objective really is the positive predictive value of the microRNA. You know, did we make the right decision? Did we avoid surgery in the patients who were microRNA negative, and they just continued on active surveillance? So hopefully this should be starting soon, and I hope to roll this out like we did with SEMS to even more centers who are interested in doing this with central assessment of the microRNA by Lucia and colleagues up at UBC. So we have a great relationship there, and we hope to standardize testing up there. So in conclusion, I think metastatic seminomas, early metastatic seminomas can be cured surgically in many cases. I advocate RPLND for stage 2 germ cell tumors, both seminomas and non-seminomas. I think microRNA 371 is going to change things in the future, not just for stage 2 disease, but also in stage 1. And also, you know, for some cases in post-chemo setting. So I think many of the rules will change in the near future. There are some good clinical trials planned to validate their utility. So I'll stop there. Hopefully I'm on time, and take any questions if you have it. Thank you very much.
Thanks, yeah. So I just have a comment. One of the questions that I often get is how these clinical trials, like the S1823 trial, has been so successful considering the uncommon epidemiology of testicular cancer and also the specific population of AYA. So we know that we don't, like, these patients are not enrolled as well as younger, older patients in clinical trials. So I will redirect the same question to you. Why do you think your trial was so successful in recruiting?
Yeah, thanks for that question. I think, you know, the germ cell tumor enthusiasts and clinicians who are experts, once you explain the concept to them, I think it made perfect sense. You know, if you're seeing those patients, then why not surgery? Why are we treating you know, a 1.3 centimeter lymph node in the retroperitoneum with the same regimen we would for good risk non-seminoma spread to the lungs and everywhere? So the you know, having the concept make sense to people, I think, is and not just for the clinicians but also for the patients. The buy-in is very, very important. So when you explain the trial, I had no trouble, you know, getting patients to sign on. It's either, well, you look, standard therapy is this. We've been doing RPLND for non-sem, and there's a seminoma for the patients. We'd say, you know, its cousin who's supposed to be slightly more indolent. So I think having a simple concept helps, and B, you know, making sure that patient advocates are on board, and making sure that, you know, the therapy makes sense to the patient as providing immediate potential benefit for them. We suspected this is going to be successful in terms of, you know, it was just a matter of where that number is going to be. Is it 70? Is it 80? Is it 90%? We knew it was going to be high just based on our experience with non-sem. And then your second part of the question, why is 1831 so successful in accruing? Because again, it's a very simple concept. You get multiple sites. 1831 is open at, I think, over 200 sites, if I'm not mistaken. They're not all expert centers, obviously, but again, it's a very simple concept. They don't need to be expert centers. We're just seeing what the validity of the marker is. And so, simple concept, you implement it, and any patient undergoing orchiectomy, newly diagnosed testis cancer, gets this test. They get accrued to this study. Now, for Majestic, I think we are going to have some challenges, and those challenges are going to be the central assessment of the marker RNA, the real-time assessment that we need, and then getting the patient scheduled for surgery if the marker RNA is positive, which we expect in most patients will be.
Okay, yeah, thanks. Yeah, I think I echo what you have said. I think that all these factors have contributed to the success of the enrollment to these testis cancer studies. Is there any question from the audience? All right, okay. Thank you, Zia.
Great. Thanks so much.
Thank you. And everyone online, thank you so much for coming. Everyone here, thanks for attending as well. And there's a sign up sheet by the exit, if you wouldn't mind just putting your name and email there before you go. Thanks a lot.
Thank you.